Hi, this is Neil Hansen, and I'm taking you through a renal mass protocol MRI. So I'll refer you first to the liver MRI video because many of the sequences are used for really similar purposes. Again, we start off with a coronal T2 weighted image, and I'll have you just look and notice that instead of being centered around the liver, we're centered on the kidneys. Most often, renal mass protocol MRI is obtained to either evaluate a focal renal lesion, such as a hemorrhagic cyst versus a solid renal mass, or to stage a solid renal mass, a known kidney cancer, for example, to evaluate if it goes into the renal vein or how far it goes into the renal vein or IVC. So it's usually a workup of a renal mass or a staging of a known cancer. The one thing that we do with the kidneys that's unique apart from the liver is we add in multiple sagittal images. So this person has very atrophic kidneys with multiple cysts, which you can see here, and sometimes the kidneys and renal masses are much easier to delineate on sagittal imaging, so we add in a number of pre and post contrast sagittal images for review. Again, the axial T2 weighted images are used really in similar manner, and again, the closer a renal mass is to CSF fluid, the more likely it is to be benign and a cyst. However, there are some exceptions that occur, so you have to be careful. For in and out of phase imaging, we can use this to look for mass. So intracellular lipid can be seen in certain types of renal cell carcinoma, such as chromophobe RCC, or macroscopic fat can be used to diagnose something as an angiomyolipoma, and we hope to show you some case examples of that in the module that's being created. Diffusion weighted imaging, I'll tell you, is very experimental in the kidney, and I don't use it for too much other than just detection, so I'm going to skip over a large part of that. Some really aggressive tumors or really cellular tumors restrict diffusion, so looking in the kidneys at diffusion weighted imaging could potentially help you with those particular type of tumors, such as like a metastatic neuroendocrine tumor or something like that. So after the diffusion weighted sequences, we go to the pre-contrast T1 weighted images. Again, this really is useful because anything that shows up right on this sequence, such as these hemorrhagic renal cysts, you can see here on the left and here on the right, are inherently T1 hyperintense, and that has a very limited differential. It could be hemorrhage, as in this case, could be melanin if the person has metastatic melanoma, could be proteinaceous debris, certain stages of calcification or flow. And of course, gadolinium causes high signal on T1 weighted images, so after we do our post-contrast images, it could be enhancement within a tumor. Here's our bolus tracking. Again, the technologists use this to determine when to trigger the arterial phase scan, and just like in the liver for a renal mass protocol, we get an arterial phase. So here's your pre-contrast, here's your arterial phase, a venous phase, and a delayed phase. What are you using these for? Arterial phase is good for evaluating the renal arteries, counting how many of them there are, describing their relationship to renal masses, and providing a layout for the surgeon in anticipation of planning a nephrectomy if that's what the patient is going to be treated with. For here, the left lower corner is the venous phase. You're looking at the renal veins, and if there is a tumor, how far they extend into the renal vein. And on the delayed phase, you're looking at that and the IVC to see if there's any contact too. Of course, on all post-contrast images, you're looking for enhancement. And I'm just going to highlight some things on this pre and post contrast. So on this post contrast image here on the right hand, you can see this renal mass here is high signal. And you don't really know, is that T1 hyperintensity from a hemorrhage, or is it T1 hyperintensity from an enhancing solid component? So you look back at your T1 pre-contrast, you can see that it was hyperintense, so you suspect that it's all hemorrhage. But what if it's a hemorrhagic renal mass, which those are not rare? So to ensure that there's no enhancement within this, we do something called subtraction imaging, which is, in my opinion, absolutely necessary for every renal mass protocol MRI you read. It's where the pixels within the non-contrast or pre-contrast T1 weighted images are subtracted away from the post-contrast imaging. I'll bring this up here to highlight it to you. So this is the arterial phase subtracted. When you look at this, and you look, I'll bring up the arterial phase for comparison, kind of sync them together. So when you look at this hyperintense T1 weighted image, and we click on an area, you can see here that once we subtract out the T1 weighted pre-contrast image signal, all the signal goes away. And so everything in this image that accounts for T1 hyperintensity was present before we gave contrast. It's all just hemorrhage. Because after contrast, on subtraction imaging, the only thing that really shows up, like here in the vessel lumen, is the gadolinium. So you can confirm that this was, and in fact all the patient's other hyperintense renal masses were just hemorrhagic cysts. In distinction, if this was a solid renal mass, that signal would not completely go away on subtraction because some of it would be gadolinium in a truly enhancing tumor. So that's what you use subtraction images for. If subtractions aren't made for a given MRI, call the techs up, ask them to make it, or alternatively on the Terra Recon program, you can make your own. So all these are arterial, venous, and delayed post-contrast imaging. We also do coronal, which you can see the kidneys here, and sagittal post-contrast imaging for renal mass protocol studies. Depending on the shape and orientation of the kidneys, renal masses, their size and their relationship to the central hilar vessels, can be easier to delineate on a coronal or sagittal sequence than on a straight axial. Additionally, just like in the liver protocol, we always get an axial T2 weighted fat saturation sequence. That's useful, in my opinion, mostly for looking for edema, so if you're looking for perinephric inflammation or lymph nodes. So I always do a specific retroperitoneal lymph node check on this sequence to assess for any possible nodal metastasis, as that's where renal cell carcinomas can go. If you're wondering, yes, this is a right lower quadrant renal transplant in this person that had pretty severe chronic kidney disease, as evidenced by their atrophic thinned kidneys. Lastly, you have the survey scan, which again is used by the technologist to set the scan up. I always check the vertebral bodies. I'll check the ascending aorta for aneurysm, things that are outside the scanned field of view in the other sequences we reviewed.
Today I'm going to go over how to review a renal protocol MRI. So as far as the sequence, this is really similar to our general abdominal MRI, almost identical. The only difference is that we've added in some sagittal sequences just for optimizing how we see the kidney. So just like any other MRI, I'm going to start with my coronal T2 and get an overview of all the organs in the abdomen. Kind of scroll through the liver, the spleen, both kidneys, both adrenal glands, pancreas. You can see our biliary system here, gallbladder if the patient has one, and colon and small bowel, mesentery, lower thorax, and breasts. Next we do our axial T2 sequence and go through the same search pattern, looking at each organ's size, attenuation, morphology. So liver, spleen, kidneys, adrenals. Here we can see there's an adrenal nodule on the left, pancreas. We can see the pancreatic duct nicely in this patient. It's normal in caliber. We can see the common bile duct also looks normal. We'll follow the stomach to the duodenum, and again, look at the upper abdominal bowel loops. So in this case where we're focusing on the kidney, most often for this exam the indication is going to be following up a renal mass seen on another modality. So here we can see a uniformly T2 hyperintense, well-circumscribed cyst in the cortex of the left kidney. The lesion that's in question from a prior exam is very subtle on T2 here in the cortex of the right kidney. So we'll keep that in mind. Here's our sagittal T2. We can get a better look, potentially, at that lesion in the cortex of the right kidney. It is T2 hyperintense, but it's heterogeneous, and it's not as bright as a simple cyst, which you can see on this same image here near the renal sinus. Next, we have our diffusion-weighted imaging. I personally find this less useful for evaluating renal masses because renal cell carcinoma may not restrict diffusion in all cases, and some benign tumors like oncocytomas can restrict diffusion. So mostly helpful for looking for anything else, incidental or metastatic in other organs like the liver, spleen, looking for abnormal lymph nodes. I don't see anything in this case. Here we have our axial T2 fat set, which gives us nice tissue contrast. T2 hyperintense structures are a little bit more conspicuous. So here's that right renal lesion, still very subtle, but a little bit less so than our non-fat saturated T2 sequence. The simple cysts look even brighter than they did on their regular T2. From there we'll move into our T1 weighted in and out of phase. So we'll unlink these, scroll through to the in phase, scroll through to the out of phase with our India ink artifact, and look for signal differences between the two. So this is a little bit more useful of a sequence than even in just our general abdominal MRI. Obviously here we can see the liver is much darker on our out of phase diagnostic of hepatic steatosis. And then we can look for other lesions. That left adrenal nodule looks like it shows gross dropout of signal from in to out of phase, consistent with a benign adenoma. But then for renal lesions, it's helpful too. So here is that lesion in the right kidney. This particular lesion looks about the same to me between the in and out of phase, but renal cell carcinomas can contain fat. Also, papillary renal cell carcinomas have a unique characteristic where they can gain signal from the in phase to the out of phase. So they do the opposite thing from fat because they can contain hemosiderin, and that is said to be a specific sign of renal cell carcinoma. So we're almost to the end. Next, I'll look at our post-contrast images. So actually this would be maybe a smart way to start the exam is to look at our T1 pre-contrast. If you see anything bright on our T1 pre-contrast, you'll probably want to use subtractions. So at this point I can see that the lesion in question does have inherent T1 hyperintense signal. So I could call the technologist and nicely ask them to please perform subtractions. That may take them a few minutes. So if they do that, you can look at the rest of the exam and then they should be ready by the time that you get to the post-contrast part of the study. In this case, they did already perform them. So instead of our arterial, venous, and delayed, we're going to have those same sequences just subtracted. So these are just calculated sequences where they have subtracted the inherent T1 contrast so that all you're left with is intravenous contrast. And these are really helpful for lesions where if you look at our non-subtracted image, it's really hard to tell if that lesion is enhancing from the pre-contrast to the post. But once you've subtracted everything out, anything that's left in the lesion that looks bright should only be contrast. The only caveat is that these are pretty sensitive to motion artifacts. So if your study has a lot of motion, I would say that the subtractions may not be accurate. In this case, there's little to no motion, and you can clearly see in the subtractions that this lesion enhances on all phases, arterial, venous, and delayed. And in this aspect, renal mass MRIs are very easy because if you have a solid enhancing lesion, you cannot exclude a renal cell carcinoma. This could also be a benign enhancing solid lesion, but we can't differentiate on imaging. So essentially this needs to be surgically removed or ablated or closely watched, kind of depending on patient factors. So in this case, we'll say finding suspicious for a small renal cell carcinoma in the mid-right kidney. And of course, on our post-contrast sequences, we're going to do the rest of our search pattern, looking for any enhancing lesions in all the other abdominal organs, looking at the aorta and its major branches, looking at the major venous structures to assess patency. finally, we have our coronal post-contrast. The coronal, I think, gives us a really nice overview of the kidneys. Also, you can clearly see that this simple cystic lesion on the left kidney has no enhancement, whereas that right renal lesion is enhancing. You can see the osseous structure, so renal cell carcinoma likes to metastasize to the bones and to the lungs. So important to get a nice look at both of those. Breast tissue, mesentery, lymph nodes. Renal cell also likes to invade the venous structures of the abdomen, so it's important to mention anything that may upstage a patient with renal cell carcinoma. In this case, this lesion is confined to the renal cortex, but you'd want to describe any extension beyond gyrotous fascia, extension into the renal vein, into the IVC, superiorly into the supradiaphragmatic IVC, would also upstage them. I have another case just to demonstrate a different finding. So if we start with our coronal T2, we can see that there are these dilated cystic structures in the superior pole of the left kidney. You can see that the superior pole left renal cortex is thinned compared to the lower pole and compared to the right side. And it has a little bit different signal. It's darker on T2 than the rest of the cortex. You might also pick up that there seems to be something causing the calyceal dilation there. If we look at our axial T2, you can again see those dilated calyces in the superior pole, and then we have this round intermediate T2 signal mass within the collecting system of the left kidney. We'll kind of skip through everything else and go on to our post-contrast. So we can see that that mass clearly enhances, and it also looks like there's nodular enhancing components within the dilated calyces. So this appearance is most consistent with a transitional cell carcinoma, and these nodular foci within the calyces are concerning for tumor extension versus some complex debris within the dilated calyx. Also kind of more subtle is a delayed nephrogram within that thinned cortex of the superior pole, suggesting that there's some functional obstruction clearly from this transitional cell carcinoma. Also important to assess for any regional or distant lymphadenopathy. We can see there are just small retroperitoneal lymph nodes in this patient, no other signs of abdominal adenopathy.